All right, everybody. Thanks for staying. I'll try to get you home soon. Venous thromboembolism, risk to rescue. I'm going to focus on PE. This is an evolving, multi-billion-dollar industry and a very complex problem that we're finding new solutions for. PE is a leading cause of cardiovascular mortality, and about 30% in all comers of untreated PE can lead to mortality. And we know from iCopper 99 that RV dysfunction predicts poor outcome in these patients and a higher mortality rate, wherein increased RV afterload leads to RV dilatation, pump failure, cardiogenic shock, and death. And it's based on this hemodynamic understanding that the current classification scheme lists patients with hypotension, CPR, shock as having high-risk PE, formerly known as massive, which can have up to a 60% mortality if untreated, intermediate risk in patient with RV dysfunction, and low risk of no evidence of RV dysfunction. You could just put these guys on a blood thinner. And so the job of the interventionalist and the current evolving practice is to identify patients at high risk of clinical deterioration and intervening in order to change the outcome. Is there a role for lytics in 25? And we know that lytics save lives and prevent death, and that's why they carry a class 1 indication in Europe and 2A in the US. However, PITHO sought to evaluate the role of systemic lytics in patients with intermediate risk PE. And although they met the safety, the efficacy endpoint with lower risk of hemodynamic decompensation in the lytic arm with an odds ratio of 0.3, there was a prohibitive bleeding risk with a 2% hemorrhagic stroke rate. And that's why the use of systemic lytics carries a class 3 indication in patients with intermediate risk PE. And thus the need for a targeted approach arose. This is the ECOS endovascular system. It uses ultrasound accelerated catheter-directed thrombolysis, CDT. This is a 5.4 French infusion catheter that comes in different working lengths and treatment zones. It's about a 15-minute case. And they have a lot of data to support this technology with the Ultima trial, the only RCT in a decade at the time that showed superiority for ultrasound-assisted thrombolysis versus anticoagulation. Optalized showed that we can use a shorter duration and a lower dose. We can do 2 mg per hour for 2 hours and still get a benefit. High PITHO compares ECOS versus anticoagulation and is going to look at high-risk patients. And this is a RCT that's long awaited. And most importantly, at least to me, is PE Track, because this is the only NIH-funded study in this whole space. And it compares ultrasound-assisted thrombolysis and CDT versus anticoagulation. And doesn't only look at safety and efficacy, but actually looks at long-term functional quality of life outcomes, which I think is a very important question in these patients. This is the Bashir endovascular system, a new thrombolytic device that combines fragmentation and lysis. It comes in different conformations. You can see here, you can get infusion through the shaft and the basket. The 7 French system is delivered to the pulmonary artery. The basket is inflated, and a milligram pulse spray of lytics is given. And then the basket is collapsed, and this is done again for another milligram. And the catheter is left in for 5 hours for 5 milligrams per hour. That's a total of 7 milligrams per lung with a 33% reduction in RV to LV ratio and rescue PE, and a reduction in PA obstruction index or overall clot burden. However, ATTRACT and DVT taught us that even with CDT or catheter-directed lysis, patients still bleed with a 5 times higher bleeding risk with use of any TPA versus anticoagulation alone. So the need for a lytic-free approach arose here. Insert the Penumbra Indigo system. This is Lightning 12. The Indigo system comes in 8 or 12 French. It's a stainless steel hypotube with a soft atraumatic tip that comes with a separator. The H-Torque catheter allows for a 50 millimeter circumferential sweep in the PA. And it also has this intelligent microprocessor that gives you some feedback. And I'll show it here. You can see the device is flashing orange, telling you you're stalled in clot. You engage the clot with the separator, it's flashing green, telling you you have free patent suction. And it also gives you audio feedback to let you know that the hemostatic valve is being activated, which mitigates blood loss and lets you know you're in the right place. And you kind of get pretty pictures like you see on the right of the clot you get out. This is the Flash 16 device, newer generation, with more powerful suction, more advanced algorithms for blood loss via its Gallop mode. It also comes with a Select Plus catheter that can work as a dilator and also allow for selective injections. This is some of the studies coming out of Penumbra, and Storm PE just completed enrollment. This is a prospective RCT that's going to look at Flash 16 versus anticoagulation, and is going to look at safety and efficacy endpoints as well as 90-day quality of life outcomes, which is exciting for a mechanical thrombectomy space. This is the Inari FlowTriever that a lot of us are aware with. It comes in 3 sizes, 16, 20, and 24 French, and different catheters I'm going to show in a second, and a flow saver filter that allows for blood return, and you can see it here, 24 French catheter delivered to the clot. The valve is closed, the suction is performed with a large bore syringe. You open the valve and aspirate. And in instances where you have more adherent clot, you can use the FlowTriever catheters, sort of a fragmentation device that allows you to pull the clot into the catheter. And you can also use the Triever 20 for curved aspiration and tough angulations. And finally, you can recycle the blood, give it back to the patient through the flow saver filter. And a lot of really good data, I think, coming out of Inari, with Flame being a potential game changer, showing a low in-hospital and 30-day mortality in patients with high-risk PE treated with the FlowTriever device, which is really a first. Peerless RCT recently compared FlowTriever versus CDT, whether it's Craig McNamara or other forms. And interestingly, there was no difference in major bleeding in Peerless, which was kind of a surprising finding. However, patients in the CDT arm were at higher risk of clinical deterioration, needing bailout therapy. Definitely thought-provoking. This is the AlphaVac system by AngioDynamics, newer iteration of AngioVac. Comes with an ergonomic handle. It's a manual aspiration catheter. You can deliver it to the clot, pull a suction, pull it back, redirect it to the right side, and perform another suction. As we begin to tackle high-risk PEs with these devices, the ability to reselect the PA without needing wire access may be a game changer in patients undergoing CPR or actively decompensating. This comes in 22 French and 18 French cannulae. This is the Aventis thrombectomy system, just received their 510K clearance. It's a manual aspiration device, a 24 French system, also has a blood filtration chamber and allows for blood return. And this device, the Symphony thrombectomy, also receives 510K clearance this year, is a continuous suction device, 16 or 24 French, comes with a ProHelix tool for clot engagement, and facilitates aspiration. And so what will the future landscape look like? I think there's more questions than answers here, but certainly I foresee that mechanical thrombectomy will play a larger role in high-risk PE patients. However, an RCT is definitely needed, particularly when it comes to comparison with perhaps systemic lytics and with safety and efficacy endpoints, but also long-term quality of life outcomes. And on the right side of the screen, I think it's still up in the air, but I think that the company or device that's able to demonstrate improvement in quality of life. Can I counsel my patient that if I do this procedure in a year, they'll be able to run 2 miles? We'll be able to dominate this space and even potentially expand the indication to low-risk PE. Take-home points, PE is the leading cause of mortality and morbidity. Lots of new toys. We need RCTs in order to find clinically meaningful endpoints, prove class 1 benefit, and be able to better advise our patients. Thank you.